How honored we are to have her with us tonight as she speaks on rethinking depression and its treatment, insights from studies of deep brain stimulation. Dr. Mayberg.
So can everybody see? You're kind of angled on this side, and I would hate for you not to be able to see the slides, which I slaved over, so okay, personal. And you just let me know. I think I can project pretty loud, but if I'm gonna, because the laptop and the projector don't go simultaneously, I'm going to look at the screen quite a bit, so don't take that as being rude, even though it is. As you can see from this first slide, I'm going to try to give a transdisciplinary talk because, in fact, to rethink about depression is to have to think about depression from many points of view. And I think that the talk tonight will be about what is the thought process that goes into dissecting any medical illness, but particularly a psychiatric illness, and to think about how one can construct models that'll allow us to understand a disease and actually manage and take care of patients in the best way possible. Because everything I'm talking about tonight is how to have people well and have that be served by, you can take care of patients better if you actually understand as well you can about the illness that they have. To do this, we what may not happen in a college, but in a medical setting, is that everything is supported by grants. And we've been fortunate to be supported by grants from the US government, the Canadian government, and most importantly, for some of the most unusual work and progressive work by research foundations that really support these kinds of ventures. And we're very grateful to several of them in the United States. I am going to also be talking about unapproved uses of medical devices. And again, the reason it's important that everyone is familiar with the disclosure so that you understand the context in which I present the work. That isn't always done in a college setting, but in a medical setting is quite crucial. And that we use devices made by various manufacturers, and this is not something that's approved to be used. So that what I'll be talking about may be encouraging, but is not yet proven to be effective. And I'll point out which things are known and are generally accepted and which things are experimental, so it will be clear. The work that we did in Canada, which is actually why I'm here, the work in brain stimulation did lead to intellectual property and a patent that we filed, and that was licensed by a company that actually has currently taken what we did experimentally and looking to get approval more widely so that it would be available not just in a research environment, but for patients in any clinical setting. And in that endeavor, it's important that you understand that I have that disclosure and that I consult to the company. But what is unusual, and what was unusual about doing much of this work in Canada, is that unlike other kinds of experiments, we did not have to partner with industry to try out our ideas, that we were able to do this through grant funding, through the support from the hospital in Toronto Western Hospital, the support of NARSAD and the Dana Foundation, and that's a very unusual situation to have been able to be creative without being regulated, if you will, by industry, because these are generally things that are done collaboratively. But this was a very unusual situation, and I think it's important to put that in context, that we were lucky, and I consider that being in Canada made that possible, and it never would have happened quite this way if we had actually started and had this idea in the States. So go team, go Toronto. So I think, before we get started on to the neuroscience, is to actually kind of get into the first person perspective. And I think I can't gauge by the audience, I don't see any white coats, so how many, just so I have kind of a sense, how many kind of medical neuroscience people are here? Okay, and how many people from the college might be, English, philosophy, history? Okay, good. And how many people from the community are just interested in the topic, interested in depression? Okay, that's helpful. So I'll try to kind of pitch this so that some things are more heavy on the neuroscience, some things are more heavy on the philosophy, and you'll let me know when we're done if anybody got anything out of it. I think that, without joking, that the important place to start to think about the neuroscience of a psychiatric disease is to start with the premise is what is a patient experiencing? Because what they're experiencing is what you're going to try to understand. And I think that, as you'll see, physicians have all kinds of ways they organize illnesses because we have to be able to communicate with one another, give orders, decide on treatments, and take care of people. But I think the first-person perspective is always critical. And I think when you think about depression, if you don't have it, you always think about the idea as it's a low state. You're blue, you're low, it's dark, you're slow. But in fact, if you listen to what William Steinman wrote magnificently about his own depression in his very, very small book, Darkness Visible, in my mind, he captured in the fewest words possible what the experience is. And in this section, and I've tried to highlight with the color the contradiction of the illness when you're in the throes of a major depressive episode. And namely that it's a madness, but it's actually the opposite of a violent madness. It's a storm of murk. And I think to just kind of conjure that up is really quite striking. Slowed down responses, near paralysis, the idea of being in quicksand for many patients. Psychic energy throttled back close to zero. And ultimately, the body is affected, feels zapped, and drained. This part then getting into nearly immobilized. And here I think is the most important part because while it's flowery prose, the notion of slowness is what you get. But I think this is the most critical part. It's a trance of supreme discomfort, an almost oxymoron in terms of the use of words. And I think it's this discomfort combined with this helpless state and a positive and active anguish that makes this illness both almost painful to read the words and try to imagine what that's like. But I think if we all put ourselves in someone's situation to be in that state, this is our starting point. So what do the physicians do? Well, we have a laundry list of symptoms, and we say a major depressive episode, you need diagnostic criteria. 5 symptoms that must include depressed mood or decreased interest. We call that anhedonia. So again, is psychic anguish captured by depressed mood? In the playbook it is, but there's a very different quality to the use of the term kind of mental pain than there is for depressed mood, and I think that's something we want to try to think about. But critically, just being sad or low or having low interest has to be accompanied by changes in sleep, weight and appetite, the rate at which one moves, psychomotor speed, this sort of pervasive change in energy. Many patients are fatigued, can't concentrate, and then this tortured state of feeling worthless and guilty for no particular reason. And this recurrent thoughts of really being better off dead, and in many cases, people making suicide gestures, attempts, or even completing that. It's clinically significant distress. It's not just having a bad day, it's a pervasive state over weeks where you really don't have lulls in your day or in your week. It impairs how you work, how you socialize, how you interact with your family and friends, and critically, that there's sort of a time lag to it, that you have those symptoms over time. So what is the stats on this illness? Very common. The estimates is that 17% of people will have an episode as just described at some point in their life. The risk is higher, it's more prevalent in women than men, and the numbers now, it's the leading cause of years lived with disability. It's an illness that generally starts in young people. So unlike other devastating neurological problems where people lose their memory, lose their mobility, that happen in late life, this affects people in the prime of life and accounting for these total disabled years. It actually is a malignant disorder in many forms because the rate of suicide is extremely high. And the numbers, particularly since we're at a college and in a university environment, it's number 2 and number 3 in suicide, outdone only by motor vehicle accidents in the age range of 15 to 24. So this is something to actually pay attention to. Doesn't get as common as it is in how we think about it. It's more serious than I think many people actually understand. So the good news in some ways is that we have treatments. There are many evidence-based psychotherapies. There are a number of medications that can be extremely helpful to many people. The problem is, and for the purpose of why it needs to be rethought, is they're not always effective. And the emerging numbers is that if the goal is to be well, less than 40% of people will be well, be brought out of an episode of depression with the first treatment that's tried. And it's actually sort of trial and error, and we don't really have good ways to know what is best for someone. Who do you go to? If you go to a therapist, they give you therapy. If you go to a GP, they don't have time to give you an hour of therapy, they give you a pill. There's no knowledge like there is if you have a heart attack to say, gee, your heart needs a stent. Your heart needs 4 vessel bypass. You're diabetic, you need a pill and exercise. No, you need insulin. We don't have prediction biomarkers like we do for cancer or heart disease. And so it's trial and error, which can work, but is certainly not the best. It's a disorder of relapse and recurrence. That's extremely common. A small percentage of people have a single episode and never have a repeat, but the disorder is really one of episodes of illness and wellness, and not always wellness back to the 0 position. The reason that we need to think about new things is really for this statistic. 10% of people become resistant to the available treatments over time. We don't understand whether or not different treatments, you get used to them, and so you adapt and you need to try something new. Aggressive process in the brain, this is an ongoing area of research. And the problem is that there are really limited options once you've failed the available cadre of treatments, including the best treatment that we have, which is electroconvulsive therapy. Extremely effective, but can have side effects. And even that, which can get people out of a very deep depression, when that stops working, your options are quite limited. So we kind of lament, well, why doesn't everybody work harder, think faster? What are the limits to why there aren't more options? The drug companies have actually moved out of the field. The very few that remain trying to look for novel chemical compounds. And the problem is we don't have pathology. You know, we've got that work list of what signs and symptoms, but unlike other medical illnesses or other neurological illnesses, we don't even have a pathology to kind of dig our teeth into and say, okay, let's try to figure out what we do because here's our starting point. And for 50 years, we've relied on drugs that modulate serotonin and norepinephrine, and that actually, we've exhausted that, and the new leads are few and far between. So, you know, that kind of gets to the last line. Well, so then what? Well, I think that, again, you know, from a kind of transdisciplinary point of view, I mean, how do humanities people kind of see science, and how actually is science? Well, you know, science, and this is from James Watson, you know, the great geneticist, and his take was, you know, science, it really isn't as logical as you think. It doesn't go in a straight line that sort of people who aren't in science imagine it must do. Instead, it steps forward and sometimes backward, and often very human events in which personalities and cultural traditions play major roles. I mean, sort of a stunning statement. You know, one like to think that science kind of moved in this linear fashion and everyone kind of knows what they're doing. You do an experiment. Medical science is not math. The equations don't always fit. And I think just to make the point is, what is it about science and depression that has made some of these historical barriers? I think it goes back to conceptual constructs. The notion of Descartes, I mean, mind and brain, and that kind of separation. And even in contemporary times, you know, the therapeutic silos. So even if you can buy into, which you must, or you will not be allowed to leave the room, the brain does mediate the mind. They are the same thing. You may not be able to explain all of it, but they are together. But even when you get into the practicality of delivering care, we have psychology with their language, we have psychiatry with its language, and we have neurology with a third language. And they kind of are saying the same thing, but it's really not the same. And that's where I think, you know, the goal of the university here to kind of even use the term, you know, transdisciplinary is extremely important, because it's not just about acknowledging each discipline, it's about actually find ways in which you define new disciplines. So what are biases that are there? I mean, if you can find a joke on it, it's real, right? I mean, the psychology has always been in depression, you know, blame moms. You know, it's something about how we were grown up. Well, it turns out, maybe not from this point of view, but that moms and genetics and early life experience is very, very important to the genesis of depression. Maybe not the way this was conceptualized, but this starting point has been very critical for thinking about the pathophysiology of depression. The chemists kind of say, look, you're just a quart low on serotonin, fill up the tank. And what's been very clear is that that is definitely not true. This is not a disorder where you're just a quart down. And if you can just replace and tap off the tank, that things will be better. Chemistry is important, but chemistry isn't the old story. Now, you know, I'm a neurologist, so, you know, obviously, if you just study, have the right tool, there's a spot in your head that can explain everything. And, you know, you can find a million of these online with so many places in the brain. There's modern phrenology, and that is, in some ways, the practice of neurology. And all of these are right, but none of them are all right. So they've got to find ways in which they interact with each other. And the etiology bias actually influences the treatment bias. So in psychotherapy, I mean, just exercise your brain more. I mean, that's actually what it's about. And pharmacotherapy is, you know, look, I don't want to have to talk to anybody, just take a pill, and it will kind of regulate things. This is always my favorite. I know people that are like this. This is, you know, some therapists I know. But, and then the neurosurgical approach is, in this domain, is really, you know, the brain is hardwired. I mean, there are things that we can do, there's things we can't do, and so why try? That's not our domain. So if we're going to think with these kinds of biases in mind about what is the next step, how can we start to think about when the status quo is inadequate, how do we break out of our own barriers? What do we do? Well, I think like anything else, and this is a physicist, David Goodstein, who said this, the cutting edge of science is actually not about, it's never about the complete unknown. It's about timing. It's about right place, right time. But I guess more fundamental is actually knowing it's the right place at the right time. And if there are things in place and one is in a position to capitalize on it, things can happen. And I think the evolution of brain stimulation, which I'll spend the rest of the time talking about, is the fact that there were some very specific scientific facilitators. So what were they? Well, how could one start to think about putting a wire in the brain somewhere with some specificity if there wasn't access to ways in which you had exquisite tools to image the brain and know where you were going? And two, would you want a neurosurgeon going in if he actually didn't have a good machine to drive that, you know, advances in the way surgeons, in the way in which surgeons do surgery, the level of precision that is possible is just light years over what it was, you know, 30 years ago, and is getting better as time goes on. And most fundamentally, because we all look for models that allow us to test out our ideas from past experience is experience in brain stimulation and other neurological disorders. So if this was 30 years ago, with me even knowing everything I know about imaging, to have made these kinds of proposals in the absence of work in Parkinson's disease would have been madness in and of itself. So again, timing, tools, and ideas. So what is the prototype? Because I think if you can have a conceptual idea of the prototype for Parkinson's disease, and this was not just because I'm a neurologist, because I think this is how we have to think about all illnesses of the brain. Some are easier than others, but it helps, as we know in Parkinson's, that this is a section out of the brain in a part of the midbrain called the substantia nigra, and this is in a healthy person. This is in a person with Parkinson's, and even without the red arrow, one can see that these black stripes here seem to be missing from the Parkinson's patient. Those are the areas of cells that make dopamine, and they substantia nigra, black, and they're missing because those cells die. So the cells that make dopamine die, so your brain doesn't have enough dopamine, among other problems, but that's the dominant problem. Well, what does dopamine do? Well, dopamine goes to very specific places in your brain, and one of the places it goes to is the basal ganglia. Here's a PET scan of a normal person's dopamine synthesis, dopamine uptake. Here's this same area here. But it isn't just dopamine here. It gives information and it delivers dopamine to other areas of the brain. So this is where dopamine is working. And here in someone with Parkinson's disease, it looks like the dopamine is okay here, but it's missing some in part of the basal ganglia called the putamen. That's the motor control area. Well, that's all fine and good, but people really started to understand how dopamine worked when circuits were constructed. People started to understand, how does the substantia nigra talk to the striatum? What are the connections? What's the cables? How do you talk from point A to point B? How does the dopamine get delivered? And people started studying the connections, the physiology, to understand the timing, the rhythms of how these brain regions work to coordinate motor control. And dopamine is here. It's connected and gives and helps to regulate activity in the putamen. And you can see that there's, like any grid, there's wiring diagrams between different brain areas. And it was with this knowledge in mind that the circuits, you can give drugs to boost dopamine. But in Parkinson's, when the dopa drugs stop working, you can actually bypass, because this whole system becomes very dysregulated. It's just not a low dopamine state. Other areas are trying to compensate for the low dopamine state. And you can actually make little cuts, little holes in certain areas of the brain, and you can improve symptoms even when the drugs don't work. In fact, they used to use these little strategic holes in the thalamus, for instance, before they even had the drugs for Parkinson's. You could stop tremor. But it was when they realized that understanding the pathology, the chemistry, the circuits, to know where to make that lesion, one very clever neurosurgeon said, well, I use stimulation to know when I'm close to the place I want to make a lesion. Well, maybe I'll just use that stimulating electrode instead, and then I can hook it up, and I can tune the thalamus directly without damaging it, and I can use the frequency of the stimulation all the time. And then when the disease gets worse, I can just kind of make the adjustment. And that was really the modern era of the development of brain stimulation in Parkinson's. So again, if you kind of think about that, even if you don't know pathology, if you could somehow figure out the circuits, you'd be in a position to think about what brain areas do I want to do what's connected to what, and maybe I can affect change even if I don't have the story from soup to nuts, from pathology to the end. So what do we, can we even think about depression that way? I mean, that's kind of really asking a lot. Is the area that's not functioning well the same for all the patients? So is it like Parkinson's disease, or is it like other things, like having a sore elbow? Maybe it's arthritis, maybe it's gout, maybe you have a fractured elbow, maybe it's just a symptom and really you couldn't, it's mediated in different ways in different people. Well, maybe we can get help if we can understand how current treatments work and conceptualize them this way and move from there. And if we can do that, then maybe we can try to understand, is one area of the brain more important than another? So we can kind of understand who might be the ringleader. Where's the intersection point of different regions talking to each other? And then we're in a position to kind of dream about novel ways that we can change the brain to move it in those directions. So how do people start thinking about emotion circuits? People have been thinking about emotion circuits a long time. Broca, had the great limbic lobe, and this really is the great limbic lobe. It's the cingulate. It wraps around your whole brain. It goes front to back. It talks to every other area of cortex, and is really always thought, because it sits right in the middle, to be the seat of emotion and kind of direct traffic. And Papes, going back into the 30s, also kind of elaborated. He has the cingulate, but actually has articulated which regions it talks to. It's the septal nuclei. If you stimulate in the septal nucleus, it's very pleasurable. The thalamus plays a critical role. The hippocampus is important, kind of memory about emotion. And there are certain parts of the cortex and the amygdala that regulates and responds particularly to novel and particularly negative events. So you start to see that people were thinking way back. They didn't have scanners. They were just dissecting brains, trying to understand what regions talk to what, and building models about how they thought emotion worked. And even in the early days, people thought enough that there were connections in the brain that when they went wrong, the best thing you could do was to try to cut them. Something's out of control, maybe you can just interrupt the bad circle. And again, the history of making lesions to try to alleviate suffering in mental illness doesn't have a pretty history. On the other hand, if you go back to think about what did people do for people with schizophrenia, with profound suffering from melancholia and thoughts of suicide, no medication. Therapy, you're gonna go into extended psychoanalysis when you have those kinds of thoughts. The thought that you could disconnect that limbic lobe and the thalamus from the rest of the cortex and just kind of disconnect this loop, this constant loop of bad information that you couldn't stop yourself, was the motivating factor in the absence of medication. And it went through a history. The connections between deep in the brain and the cortex were cut. Then people got a little more refined. They started making cuts around the cingulate tracts. And still in contemporary times, in very, very restricted situations, lesions are still made with the notion of disconnecting bad information flow. The problem is no one ever did a controlled clinical trial, meaning that no one ever actually really looked, did it actually work, or for who, with any kind of criteria. So it's impossible to go through the old literature to actually figure out if people did okay, who were they? It wasn't really clear what you were treating, so there was never a systematic study of which symptoms. There were lots of procedures. No one ever stopped to figure out which procedure for which person, or even, quite frankly, what was being disconnected. Just a lot of hand-waving and disconnection of deep to superficial, and they were right, but not with the kind of precision you might like. And by the time anybody might have thought to try to figure out what was happening, the first medicines came in. And as soon as there was a medicine, the surgery was over. And this was the same in Parkinson's disease. When DOPA was introduced in the early 60s, the lesions stopped. And it was a renaissance of lesions when it became clear that drugs had a shelf life, that they stopped working in Parkinson's as well, that they could alleviate symptoms, but after a while the side effects exceeded the symptoms of the disease, and that you couldn't get a balance between not being frozen and shaking from your Parkinson's and actually being wild with your movements from the effect of the drugs. And the idea of how to use surgery in an evidence-based way reemerged in the late 70s. And I'm not advocating this, but the idea that this was just a bad historic period, it's only bad in retrospect. And the worst thing that went on with this historic record was the fact that they didn't actually evaluate what they did. They never went back, if you did 1,000 cases, to know what happened to those people. So it was bad management, not necessarily a bad idea. But we live in contemporary times. What can we know and say, we're going to build a circuit? We're going to see if we can build a circuit. And instead of having that laundry list of symptoms, let's say we have mood, cognition, these circadian or vegetative symptoms, appetite, libido, sleep, and this motor problem, fatigue, trouble kind of getting the engine going. And as neurologists, and in the 80s, the Parkinson's patients were trying to say, this is kind of like Parkinson's. They have motor with slowed thinking, problems with blood pressure and circadian rhythms, and they also have mood problems that maybe the same models for Parkinson's would make sense to build a model. And they already had done a lot of legwork. They knew that there were parts of the frontal cortex that very exquisitely talked to areas in the basal ganglia and the thalamus. And they were organized into runways, into pathways, into circuits, into loops. There were all these terms. And you can start to say, well, maybe these map on to these functions. And that was a beginning point to try to map the symptom to a particular brain system, not just a brain area. So what are the other ways to start to get what are these component pieces? Well, you take examples of when there's damage to the brain and people got depressed. If you look at patients with strokes, certain kinds of stroke lead to a depression that a person didn't have before. Just like a certain stroke can make your arm weak or make it so you can't see or affect your coordination, there are certain strokes that are associated with a depression after stroke. And they tend to live with damage to the left frontal cortex. People said, well, we've got scanners. We can start to make measurements in just regular depressed patients. Are there areas of the brain that are small or deformed or atrophic or are different from healthy people? And one group started to notice that there was an area called the ventral or inferior midline frontal cortex. This is in an area near the cingulate that we talked about before in the great limbic lobe and on the lower bank. And this was small on measurements with an MRI scanner. And in postmortem brain, there were abnormalities in certain kinds of cells. Another group said, no, we're finding that the memory areas, the hippocampus, areas that seem to be first line for responding to stress, those areas shrink in people who are depressed. So here started to be 3 potential nodes in a potential circuit that might actually disrupt function in depression. So the other strategy was to say, let's look at how the brain is working. Because because we have people are alive, you can see abnormalities in the brain even when they're not alive, but depression tends to come in episodes. You can be sick and well. What is happening with the brain if the brain may just not be working in particular areas, which areas? And so here is a blood flow scan, kind of ancient history, but a very good example. Here's the nose, here's the back of the head. You look at a side view, and you can see that the activity is pretty even throughout the frontal cortex. Here's the low part and the high part. And here in a single depressed person it looks like the activity in the frontal lobe is down, which it is. And if you actually were to make a slice here and now look with the scan down, kind of a bird's eye view, and actually in the computer take a bunch of depressed people, scan their brains, and then actually make adjustments to the different sizes of different people's brains. This is a very standard convention in brain imaging now. Here's 25 people averaged together. Here's 25 depressed people averaged together. Instead of just looking for an area that's funny, here is in the computer comparing every voxel in the whole brain between one group with the other group. And here is literally, in essence, a subtraction of what's different between the two groups. And you start to see, gee, there's our friend, the frontal cortex. on the right and the left. Here's abnormalities of low activity in the cingulate. And there start to even be some changes that aren't even in the frontal lobe that we wouldn't even have thought to think about, so that you let the data tell you what's different statistically. And now all the pictures I'm going to show you, whenever you see blue, it's a contrast that means the brain is low. If you see red, it means the difference or the contrast is high, and I'll just use that convention. You could start to say, okay, that's kind of interesting. Some frontal lobe activity is down. Let's take some different kinds of depressed patients. You can look at patients who have strokes, like right here. Here's an area of the basal ganglia that talks to this area of the frontal cortex. Take people with lesions here. You see a little problem with the metabolism there, but when they're depressed, they get a disconnection of the whole frontal cortex, that a deep lesion disconnects by the communication stream, by the connections, the frontal cortex. And this is the difference pattern between people who have a stroke and are depressed versus people who have a similar stroke and aren't depressed. That's where they're different. Same in Parkinson's disease. Some patients have depression, some people don't. When you're depressed, you have that same band of frontal activity being down. Another neurological disease, Huntington's disease, patients get depressed. Didn't really matter what neurological disease we looked at. If you had depressed, you had low activity in your frontal lobe, your cingulate, your temporal lobe. There was a whole set of regions that had low activity. We saw the same thing in unipolar depressed patients, bipolar depressed patients, that there seemed to be something in common. So we thought we were doing good. We had all these patients. We had them in Baltimore. We had them in Texas. But you know, it turns out, like anything else, it wasn't so easy. It wasn't just these areas being down. Some people were saying, no, some people, their frontal lobe isn't down, it's actually overactive. That made me extremely uncomfortable because all the patients I'd ever seen had low activity. So I don't know who these people are, whatever they're doing, it can't be right. But they also were saying, well, the amygdala has high activity and the thalamus has some high activity. And still, we weren't seeing those patterns. And again, you know, statistically, you follow your own data, but you have to be very cognizant of other people's data too, because they may be seeing something that you just don't have a good angle on yet. And when I first moved to Toronto, I recruited a group of patients to actually get cognitive therapy. And those people sought out being involved in the experiment. And when we scanned their brains to see where their starting point was, well, here's the front view of the brain, and if you remember the color scale, we didn't compare them backwards. We had a group of people that were comparably depressed to a group of people who came in to have a study that involved drugs, except one group had low metabolism and one group had high metabolism. So the take-home message is, we don't know what we're doing, or, which is certainly what some people thought, or the idea is that the picture is more complicated than we thought. But remember what I said at the beginning, one of the big problems is not everybody gets better on whatever you treat with. So maybe actually there's something different about your starting point that you have to get a handle on. And so we had to really kind of think about how would these networks actually work? Well, you know, we might have a network of all these different brain regions talking to each other, and something happens. And as the brain kind of shifts into a new state to react to the provocation, sometimes that shift is what gives you the signal that it doesn't feel so good, it's a bad day, and you kind of readjust. And in other situations, it is a little more severe. And you know, the thing we'd never kind of considered is the brain just doesn't lie there and take it. The brain makes adaptive maneuvers. It wants to go back, it wants to right itself. You know, if someone says something to you, you fight back. If you tip over, you tip yourself back up. I mean, the goal is to be at equilibrium and to roll with the punches. But how you roll with punches may be very different. And so maybe illness and the scan should be seen as, you're not seeing just what happened to the brain, you're seeing what the brain tried to do to compensate. So one person increases the activity in the frontal lobe to compensate, and another person can't increase the activity in the frontal lobe. And depending on how you compensate, will actually help you to know what you might do to get the brain back to equilibrium. Hypothesis about how we might think about it. And as we started to study how does your brain change with therapy, or how does your brain change with medication, it's easier to just look at it this way. We had this like whole grid of brain regions, that some brain regions change with drugs, some brain regions change with therapy. You know, no big surprise that therapy tended to work on systems that regulated emotion, that were responsible for self-awareness. I mean, what do you learn in therapy? You learn how to evaluate incoming stimuli and reframe it. If it makes you feel bad, to kind of say, well, what did that really mean? Was that them or was that me? And you have to train to do that. It is mental calisthenics. It is mental exercises. I mean, the joke was correct. And these are the brain areas that you use. In contrast, when you recover from medication, you actually target deep areas of the brain stem, the hypothalamus. Patients also often have changes in sleep and appetite and those functions before they actually have a cognitive sense of actually feeling better, because you're working on deep structures that impact the thinking brain secondarily. So you have this big model and you say, okay, what did she say she was going to talk about here? We're talking about how would you ever reach a place where you could put a wire in the brain or even think to put a wire in the brain. Where are we going to put it? There's lots of real estate all over the brain. Is there any place here you would dare try? No, because there's equipotentiality here. It's not quite clear. So the question is well, maybe we need to like refocus, because there were a whole bunch of behaviors here. Emotion regulation, cognition, mood state. You know, which part really is the driver in depression? Well, I think personally that the real major driver is what you can see from history. What do people write about depression? They write about despondency. They write about anguish, mental pain, psychic neuralgia. I mean, William James said it before William Styron said it. This is the core feature. You know, you can be anhedonic. You know, there's a lot of unhappy people. It doesn't impact that you can't think straight and you can't concentrate, and you aren't depressed because you aren't happy. So absence of happiness is not depression, but mental pain robs you of your ability to experience pleasure. So the issue is, maybe the hypothesis is that if you can't get out of the negative mood, everything else is the attempt to actually respond to that. The context of understanding how the antidepressants work, where we said, well, let's take some healthy people and just have them think about something that makes them sad. And normal sadness isn't the same as the abnormal pain of depression, but it at least is in the right genre. And if you have people think a sad memory and do it while they're lying in a PET scanner and kind of relive the moment, have an episode, imagine what it felt like when your partner died, your cat got sick, that something that was really a loss happened. And remember not just what it was in the abstract, but how it felt. If you let yourself do that, everyone can actually evoke very intense negative feelings. And if you actually have someone not fight it and just feel bad and take a picture of what's the difference over 5 minutes between neutral mood and sad mood, you get this. Area of the brain that becomes the most activated when you get sad is an area called the subcolossal cingulate, area 25. And it's deep in the brain. It's part of Broca's great limbic lobe, and it's in the most primitive part. You also get changes in areas called the insula, the interoceptive parts of the brain that actually, the icky place. It's areas where disgust is registered. It's kind of where you just have that queasy, uncomfortable feeling. And those areas are highly activated when you feel intensely sad and you turn your frontal lobe off. So there's an interplay, even with healthy sadness, of the emotion and the cognition centers of your brain in a tug of war. When you feel sad, I mean, just think about a time where you even heard a story and it made you feel bad. For those few minutes, everything else outside yourself just kind of falls into the background, and you become very, very internalized. Even if it's a story about someone else, you start to imagine it happening to you, and You know, and then someone knocks on the door, the phone rings, or the story changes, and you flip right back in. Your frontal lobe comes right back on. The emotion dissipates. And this is a system that seems to be critical for that. And it turns out that when you recover from a drug, using a drug, to go from ill to well over 6 weeks, and you take a picture of that change, it's the exact opposite. You downregulate these negative centers. Here's area 25, here's the insula, it's blue, it's turning down. Here it is over 5 minutes, getting sad. And you correct the frontal cortex. The frontal cortex and area 25, they're reciprocally interacting with each other in both situations. And so suddenly you have the model where you can take all those regions that were involved in lots of things and say 25 and frontal cortex are in this dance, and that you need to be able to change that balance in various ways. So that still gives us 2 regions, so we're doing better, and the frontal cortex is big, big real estate. Area 25 is actually pretty small. And there was something really striking about this area 25, this subcolossal cingulate, that actually there were all kinds of emerging experiments that if you provoked an emotional state, generally negative, it activated. This is actually really in the same area that had been reported to have the cell loss with people when they were depressed, where the volume was down, the glia were abnormal. It turns down with various drugs. All the SSRIs, we've studied 3. Venlafaxine, a mixed serotonin norepinephrine drug. This area even turns down when you get better when you take a pill with nothing in it. So a group of patients who were part of a study we were doing that got placebo were in the hospital and they recovered because people can respond to placebo. The ones that got better downregulated this area as well. And as we started to look in the literature of all the treatments that were used for depression, transcranial magnetic stimulation, electroconvulsive therapy, vagus nerve stimulation, they all affect lots of areas in the brain, but they all affect area 25. And so suddenly we can revise our hypothesis and say, maybe the problem with resistant depression is you actually can't respond to a fixed state of an activated area 25. And it's a funny place in the brain. Again, this is for the anatomist. It sits at an intersection. It's a very old area of brain. Lizards have area 25. Lizards don't have frontal cortex, but lizards have an area 25 equivalent. It talks to the hypothalamus. It talks to areas to regulate basic drive states. It talks to the brainstem, to areas that regulate pain transmission, to the amygdala. It receives information for the hippocampus to put emotion into context. It talks to the thalamus, the gatekeeper of the brain. It has very specific connections to parts of the basal ganglia that are important for reward and the sense of pleasure or motivation. So it sits, and if it isn't getting its message out, if nobody's listening, it wreaks havoc on the entire system. So the new hypothesis was, if something negative triggers activity in 25, usually frontal cortex will make a maneuver to be evasive. Other brain areas will try to kind of work around and re-regulate the system. But what happens if you actually have no reaction at all and you have a total state of area 25 and its colleagues actually maintaining a state that you can't turn off? So that, is this about area 25? Is it about its connection to other areas? Is it the downstream effects that aren't providing the feedback system? That's the question. So if you kind of consider then back to what did William Styron describe about his depression? The pain is unrelenting. There's nothing I can do to stop it. And what makes it intolerable is that nothing will ever happen to make it different. The hopelessness is what's so horrible. This is written by a man that when he got an antidepressant was well. So imagine, I think a very important point as we move to the stimulation, everybody that has a full-blown major depressive episode feels like this, I think, at some degree. The difference is can a treatment get you out or not? So it's not the severity, it's actually the immobility of the brain to actually get away from the sensation. We had this hot spot. We knew it was connected to a bunch of these regions. This is what you draw on napkins. This is what you put in papers. Honestly, I found this on the internet. I drew this for someone at a meeting, trying to explain what we were doing, and I guess they liked it. I guess that's sort of like someone going through your trash. But anyway, it's useful because, I mean, that is the idea of in your mind's eye. Here's the great limbic lobe. Here's area 25. And it's at an intersection for a lot of traffic that's pretty important. So we decided that that was our target. We could get into an area that if we could turn this area down and could hit the fibers that we're talking to all these other important areas, we could reset the system and maybe correct all these other poorly responding network. And that we recruited a small number of people. We had permission to do 5 patients. That we would look and see, could we safely implant people in this area? And if we use stimulation in the way they did for Parkinson's disease, what would happen? And what do? This is the battery pack. It's like a lighter, a little bigger than a lighter. And this is the electrode lead with 4 little contacts, 1.5 millimeters in length, and width. It's sort of like a strand of angel hair or pasta, very flexible silicone with these titanium electrode contacts on the end. This contraption is called a frame. This is actually attached to the skull, which allows you to put someone in an MRI scanner so that you can actually know where exactly you are in 3-dimensional space to actually make an opening in the brain and actually place that wire exactly in an angle where you want it. And that's called stereotactic neurosurgery. So it really is driving in 3-dimensional space and using 3-dimensional dimensions to put something exactly where you want. This is a simulation of the electrode of exactly where we want in area 25, right here. We have the white matter bundle, that's the white stuff. We have the gray matter, area 25 wrapped around, and we're going to have contacts that when we give current will impact the cortex locally and will travel along those white matter bundles to wherever it happens to go. And you can see we could stimulate up here. We've got 4 potential places. So what do? We're in the operating room. We stick the electrode in and turned it on. So we started with 1 contact at a time, the bottom one, turned it on, turned up the current, nothing happened. Turned on the second one, turned it on, turned up the current, and the first patient started to wonder, did you do something? I feel a little calmer, I feel a little different. And a very sort of non-specific but sort of profound set of statements by different patients, not all the patients, but we started to get a pattern in the first group. Of the first 5, 3 out of the 5 kind of reported something at some contacts that all had something to do with lower distress. They didn't feel happy, they felt a relief, there was a lifting, people felt lighter. And when they started to notice it, it was followed by, they seemed more interested in the room, they asked more questions. This has been a long time in the operating room, 3 hours. And they seemed to talk a little faster. Some people asked if the room lights were turned on. There was just a shift in how they were paying attention to things that were happening. Bad happened, which was really good in the operating room, because that's why we turned it on in the operating room. We'd never expected there would be anything good happen in the operating room. We wanted to make sure we didn't make people more sad. Maybe we stimulated and it would get worse, as opposed to stimulate and turn something. It was totally to turn it on, to kind of know what would happen. And then the idea is we would do scanning and we'd figure out which one of those contacts would turn down area 25, and that would be what we did. And so we had these interesting effects. It didn't seem to be helpful for anything. It was kind of interesting. And we sort of noted it, but not everyone had it, and even people that did well didn't have it, so we kind of moved on. This was just my favorite. One man said, after he said he kind of felt like cleaning out his garage. So that's what increased interest and energy is that, actually what he said was, I know this is sort of ridiculous because I'm bolted into this machine, but, if I was home right now, I'd actually sort of feel like I should clean the garage. And so, people were very excited about that. So we would always ask people that question, what they would do if they were home, not if they would clean their garage. But he made this kind of point, and this is why modeling these things is so complicated. Where do you try to localize when someone says, the best way for me to explain what's happening now is that it's like I've been locked in a room with 10 screaming children. Constant noise, no rest, no escape. Whatever just happened, the children just left the building. And it turned out, it's like, what does that mean? It turned out that this was a man with 4 children who, as he suffered and didn't want anyone around, having his children and their friends and everyone there was just a painful overload experience. And that was his metaphor of a change in that sudden relief. And, we didn't understand what we had at the time, but our approach was to say, well, let's turn it on and see what happens over the long haul. And in that first group of patients, what happened over 6 weeks is they went from profoundly ill with an average length of illness of 5.5 years to actually 4 of the 6 of them were better and 3 of them were well. And going with the scans, we had overactive 25 and underactive frontal cortex that reversed with the chronic stimulation. So this battery is in the chest, it's giving current into the brain. We're tuning it just like they did in Parkinson's. They used high-frequency stimulation, we used high-frequency stimulation. They left it on all the time, we left it on all the time. We just did what they did and said, if it doesn't work, we'll try something else, and it worked. So we expanded the study to 20 patients in Toronto, and this is the change in their depression score over the year. Over the first month, on average, the group was dropping their depression score. Not all the patients got better at this time rate. We had patients that actually got better after a year. But this was the tendency. 60% of these people were better. And if they got better, they stayed better. Followed these patients out longer. So this is all from Toronto. And out to 3+ years, this same kind of tendency picked up other patients that had not been doing well, that with continued stimulation did well. But importantly, it was like if you got well, even if it took a while, you stayed well, that there was a change in your resilience. So I moved in this kind of somewhere in there, I moved back to the States to Atlanta, and I had a new team. And so, everybody wanted to go, well, maybe it was a special in Canada, or maybe, well, actually for a while, people thought like it was me talking to them, and it was like, if I had this power to make these kinds of people well, I would be in a large arena doing something else. But, and so we said, there was a lot of criticism that, well, we hadn't blinded it, that we knew it was on, the patients knew it was on. There's always a placebo effect. To agree to have experimental brain surgery, to be that sick, don't let anybody ever say, oh no, they're too sick to have a placebo effect. There's always the possibility for placebo. And that's a good thing. But if you are trying to be an advocate to do surgery, you have to test it. So we did, because this was now already going by the company, had taken this on, and they were going to do the definitive test. They would implant people. Part of them would be on 6 months. No one would know if they were on or off. Part of the group would be off 6 months. No one would know. Patients wouldn't know. Raters wouldn't know. Doctors wouldn't know. You either got better or you didn't. Said, well, they're going to answer that question. We'll do a month of a blind because we really want to know how it works. And we want to know if what happens is Can a bipolar depressed patient? I mean, those patients have a lot of trouble with depression too. So we did our study. We got a similar response to Toronto. Bipolar patients responded the same as unipolar patients. If you're stuck down, this unsticks you. This is an antidepressant. It doesn't stabilize your mood. It gets you so you have mood dynamics. And all the patients that we did are stuck sad or stuck dead. I mean, no dynamics of mood. And so we couldn't make the bipolar patients manic by even turning up the current. So whatever we were doing is very much an antidepressant. And then the thought was, well, what happens if you turn it off? Maybe if you're well for a while, you can turn it off and it's fixed. Well, no. So at 6 months, the first 3 people, we did a blinded, we didn't tell them, and they didn't know when it was being turned off. They all had symptoms come back over a week, 2 weeks, kind of a slow slide, feeling slow, feeling less energetic, not feeling profoundly sad. That kind of came later. Turned it back on, and it took a while to get it back. It wasn't automatic. So we got a little spooked and said, that's the answer to our question. We don't need to turn it off. Certainly needs to be longer than 6 months. With medication, the recommendation is you take a medication for a year. You don't turn it off. You don't stop taking it because you feel well. And even with the stimulation, it's the same thing. So what becomes the next step? It seems to work, needs to be tested in experimental studies, needs to know if it really works by doing it by people other than highly vested experimentalists, needs to know if regular psychiatrists and neurosurgeons can do it, or does it take, special something? But the big question is once you start to get 60% of people well, then everybody wants to know, well, what'd you do wrong? How come everybody isn't well? I mean, it's all equilibrium. I mean, the take-home message of tonight, life is about, homeostasis, having your own equilibrium point. So whatever has been, it's just a new set point. You're not well, and now it needs to be, why not? If before it was no one got well, now it's 60%, why not everyone? So it's a challenge, but it's an important question. Why doesn't everyone get well? And there's 2 choices. The doctors didn't pick the right patients, or the surgeons put it in the wrong place. And, each side can point the finger at the other of whose fault it is. The issue is you've got to look at both. So the first thing is to blame the surgeons. And the surgeons, if you actually look at where active contacts were in the Toronto group, there's a cloud all in the approximate right place. And if you look and try to do some standardization, say what's different between the responders and the non-responders, the answer is nothing. So where doesn't explain it. And we thought, well, we'll try that also at Emory and see. Well, my new surgeons are even better than my old surgeons because they can even more precisely get it to the same place over and over again. But we didn't do any better to know where in the brain. So just having a coordinate and saying, drive to this location and that's the spot, that doesn't explain it. So we started to say, let's go back to what do we know? It's not about Area 25. There's something about the network. That 25 is at the intersection, it's the central hub. But we already knew, even in those first 6 people, that we never miss changing the activity in Area 25. But we didn't necessarily get out of Area 25, and if you didn't affect change outside of the region, you didn't get better. So we looked at the MRIs and said, well, here's approximately where our electrodes is. Well, there aren't these colored lines on the brain, but you can see where the white matter connections are, where the cables are, even on one person. And there's scans you can do that actually, like I showed you, we have the MRI for structure, we have the metabolism, the PET scans for metabolism and function. There's other kinds of MRI scans that look at diffusion of water, and it moves and gives you a signal along the white matter connection tracks itself. So we said, let's try to get an idea of what the average shape and direction of those tracks are, because here's the electrode, an X-ray of the electrode on top of the MRI. And if you imagine I can stimulate in the first one or the second one, If you just look with your eye of where those white matter pathways are going, the one at the bottom is going to go in a totally different roadway than the one at the top. And you can start to take these diffusion maps, they're called Tractography Maps, DTI, and here if you look at where contact 3 is going compared to contact 2, you impact totally, totally different connections. Okay, we want to know if you get well, what did you talk to from that current? And we got really fancy. We have these engineers model how much current, how it spreads, which electrode, which setting. So we can get extremely fancy and come up with this kind of volume of tissue activated as kind of a seed that we can put on these white matter tractography maps. And we say, okay, if you're better at 6 months and you got an electrode going on each side, where in the brain did the electricity move along those white matter tracks? And we want to know, what do these 7 responders have in common? Not on average, but if everybody's better, they all must have something identical. And that's all I want to know. I don't know where, I want to know about each one's individual variation. I want to know what they all have. And here's the map of all the responders. And here's another way to look at it, just without knowing any anatomy. And here we take the people who didn't get better, do the same kind of map, and if you just kind of don't know much about anatomy and just follow the color, you say, okay, those look pretty close, until you superimpose them, and you actually find out that you don't get to the medial part of the frontal lobe, an area that actually is the big target of cognitive therapy. All the experiments, what does the medial frontal cortex does? Where you do self-reference, where you project yourself in communication with others. It's kind of the way you project yourself into the future. If you don't get that area connected, you don't get well. So it's really interesting about what connection you needed. Even though the real plan was a turn-off negative, you actually had to re-engage in a connection where you could kind of interact with others. And in fact, we were led to this because one of the patients that hadn't gotten well in Atlanta, we just really thought she should have been well. I mean, we didn't have any good psychiatric explanation for why it really hadn't worked. And we were entertaining this idea of you had to get into these frontal connections, but we really didn't understand it yet. And we looked after 6 months, she hadn't gotten better and was very, very disappointed. And we looked at where her electrode was, and here was the track we kind of were guesstimating was needed. And she didn't have one that reached. And so we discussed with the team that maybe we should bring her back and revise it, which required another surgery. And she was agreeable to do that. And we moved it down a little bit. And now we had, the third contact here was right into that track. I mean, we really had only gained a couple millimeters. The total difference between a non-responder and a woman who's now well after, 12 years, who's not looked back. So again, the where became essential. It seemed like it, how can a couple millimeters make a difference? Well, all I have to do is miss an exit on the highway. It makes a difference. First surgery, it went in one direction, and second surgery got to the front of the frontal lobe, and that's what made the difference. So the next step becomes, and I'm almost done, how do we get into a real window now to know what we've done? What do these areas do? Well, we now can do experiments that when we're in the operating room, we can talk to the brain, we can listen to the brain, we can get an idea about what are the cells doing when they experience a challenge. And in Toronto, we had people while they were sitting in the chair while we were figuring out where precisely we were going to go, where you actually listen to the cells in area 25 around where we're putting the electrode, and you're showing the person, but you're showing the brain through the person's eyes. What is the response of area 25 when you see pictures that have emotion? happy pictures, sad pictures, disturbing, exhilarating. And there aren't a lot of cells that react. And that may be because the system is we know the system is not normal. We can't really compare it to anything. But it turns out that there are cells that respond to certain kinds of emotion. And some cells actually will respond to both. So this area doesn't just do negative. It actually does positive as well. And it looks as though it gets into a bias state that in the patients, they tend to be more driven by negative, which is something that we know about depressed people. And it actually may be manifest by even how the cells themselves respond. We don't know what happens if we do the stimulation and they shift, if the cells would respond differently, and that's something we're going to do. But I'm just going to say, that original thing where we in the operating room, I'll show you the date on this. 1986, I was, just learning about PET scanning and had this calendar, and who knows why I saved it, but it turned out to come in handy. Remember when I talked about those first thing in the operating room for safety with people having lifting, having those interesting phenomena? Well, we said, let's start to look at that more seriously. What do people say? When does it happen? Can we predict it? You can see the kind of things people say. Happens in about 15 seconds. Well, we said, okay, if we've got the connection pattern that leads to wellness over the long term, let's figure out if it only happens on some contacts and not others. Let's look at what the connection pattern is with those contacts that give the effect and those that don't. And if we do that same track map on those electrodes that give those little emotionally uplifting quips, it turns out here's the pattern. Here's, for reference, the pattern of the 6-month response. And if you overlap that immediate change that happens when you hit the switch on the right place, it is what you need to be in to get well. So we now have a way, before we go into the operating room, to literally know that we are in this map. We are going to cover this real estate. We can actually predict, implant, and know that when I hear that that's happening, even if I don't know which contact we're on, we've been 7 for 7 to actually have predicted that that's the place. And when we stimulate the person long term in that location, those patients have all done well. So we've gone from kind of that big red blob, figure out what we're going to do, to actually using all of these different tools together to kind of get to where we can be very precise to plan in advance. This is the map that I can do on my laptop in the operating room. We'll be able to transfer this kind of map. This is this person's connections. And I can drive around with this little mouse until I get to where I get to the frontal lobe, I get to the thalamus, that I get into the groove of the whole connection. Start to look at when you stimulate, what is the brain's response? We can start to make measurements in the operating room and really start to understand what we're doing. So 5 more minutes. Back to reality. Because, as a neuroscientist, and, again, my job now is to figure out what we did, make it better, and maybe get something that doesn't need a wire in your brain. But at least if we're going to have wires in people's brains, to actually capitalize on the opportunity to learn something as much as we can. And every patient is a collaborator of ours. People come and work with us, and our dialogue with them is to actually learn about what their experience is, because this is not, last year's antidepressant. And it is an obligation for us as scientists and as physicians to take best advantage of that collaborative relationship with the patient. And it's empowering for patients, I think, but it's actually mandatory for us to be able to learn from them. And I'm, profoundly grateful to the patients. But the other thing that's happened over time, and again, things don't always go perfect. But the issue is that you also start to realize that even what you thought you were doing with this profound, this new mapping, to be able to have this kind of precision, to really get to where we can make these predictions has been just in the last year, less than that. So we've been working on this, knowing that we've got to get to where we can have that level of precision. But when you really think about it, recovery, even though we can get right in the right place, consistently get that acute relief, that is not recovery from depression. That's step one. That's like, you're in a locked room, and if the door isn't unlocked, you are never getting out. I don't know if you're going to go out the door, and I don't know what you're going to do or what you're going to find on the other side. But if the door is not unlocked, end of discussion. So going from the ideas, we think how to unlock the door. But the issue is that is like the beginning of an extremely long journey, and people hear it as, oh, it's a rapid-acting antidepressant. No. And changing and reframing expectations, because all anybody remembers is hearing about someone talking about seeing the light, feeling good on the table. If somebody has got your arm in a vice, in a pit of fire, and takes it out, that actually feels pretty good. That is not joy, that is absence of pain. And I think that's actually all we do. But reframing it, because unless I think you're in that place as a patient, you can't get it. So now we actually realize our work now starts to actually help a patient reframe what is happening. And the ethical obligation of the team is more than a good surgeon, precision of placement, knowing what we're doing with tuning it. That part's easy. People want to be better now. And the bottom line is it takes a while. Even how you view the pain changes as you go from total on fire or can't move to people feeling like, okay, I never want to be there again. Well, but you're going to have to learn to know what having a bad day feels like, because you're going to have bad days, and it's different from actually having recurrence. There's actually even a burden of being well. If you've been sick for 5 years, 10 years, you're not in a good place, but you're probably in a kind of equilibrium in a pit, but it's sort of safe. Not where you would choose to be, but at least you know as it is. You kind of almost get to where you don't expect anything. But as soon as it changes, your whole perspective totally is different. So this is always a dynamic system. It is what it is until it's something else. And that's now your new equilibrium point. And how do you help patients to understand that the door is unlocked, but it's up to you to actually walk through the door or not? And that you focus on symptoms differently when all you want is for the pain to go away, and you have new priorities when actually you realize it's not coming back. And that's actually when the hard part starts. And a lot of it has to do with habits. And the issue is, what is therapy? What is rehab? It's, if you golf, if you play tennis and you hit it into the net, hit it out into the trees, you think you know what you're doing. You keep doing it over and over again, and you keep doing it over and over again wrong. You got to get help to kind of figure out what you're doing wrong. You got to unlearn the bad habit. You got to relearn the new habit. Habits is how we live. When you're really ill, your whole goal is survival. And the net effect is you have all these adaptations to get you through every minute of every day. And now that the door is unlocked, your new state is not helped by all those old habits, but the habits are all there. I had one patient describe it. It's like, I know it's gone, but it's like there's still a ghost. I find myself doing certain things. I'm not really sure why, but that's just kind of what I do. People are better, but they don't even know it because all they see is their old habit. And your old strategies are just kind of no longer relevant. So you have a kind of disconnect between what you think you should do and what you do. So you have to learn how to change habits. And I think this is that, the DBS kind of breaks the cycle and enables the new learning, but you actually have to move your curve over. So just to end, I think that for patients in this state, for us to really conceptualize depression, DBS has given us a window into how these networks work, what negative mood is, what purpose this kind of profound negative mood serves, and what happens when you can switch it. And by listening to patients, they help us quite a bit. You know, people always say, well, does it make people happy? You ask patients. And patients say, this is patient number 5, adamant, you know, it isn't like you gave me anything. That was the tone. You didn't give me anything, but you took something away. And to him, it was a feeling that he was in a vortex, kind of being in a vacuum, being sucked down. You know, he's not moving, he's standing on stage. What is that feeling? And that feeling disappeared on the operating room table, and he didn't say a word because it was always there. How could it not be there? I'm not even going to tell you. And that wasn't the deal. Patients are supposed to tell us when something happens. And that was so alarming to have it be gone. They didn't say anything for 3 days. But he says that now that that's gone, instead of being in this very deep canyon, I'm up on this ledge, but I've got this huge way to go. And the difference is that now I'm kind of part of my own solution. I can climb. I can figure out where I'm going. I mean, is that plasticity? Is the first state a change in a system reset, the unlocking of the door? But the bottom line is you actually have to have rehabilitation to help you make that climb. People can do it by themselves, but you know, you can have a hip replacement and you can do your own physical therapy. Trainer's better. And you know, our job is to figure out the optimum way to do that. Now, patient in Toronto that, not in Toronto, in Atlanta, she's from Toronto, that's why I said that, that we reoperated on. This is how she put it. She goes, DBS doesn't make it easy, it just makes it possible, because now my efforts have impact. And I think that at the end of the day, is recognizing that in any exploration of any medical problem, of anything that we do, that it's bigger than any of our experimental perspectives, whether we're philosophers or psychologists or neurologists or surgeons, that it all is, each participant has a perspective that all has to be factored in. And the challenge becomes, which part do you need to focus on first so the rest of it is very clear? So this is my team. And the team in Toronto, you know, is just so important. Andres Lozano and Sid Kennedy and Clement Hamani was the people that were fundamental to those very, very first experiments. But then I have a group of people who work with me on the therapy, on the imaging, and the physiology in the operating room. And you can see it kind of takes a village to do this kind of work and have a team of people across many, many disciplines kind of come together and do the work. So I've gone on indefinitely, I'm sorry, but thank you for your attention and your time.